If you work in a hospital and are regularly asked to analyze ABG strips, this video is for you. Before you even look at a single number, you have to start with the absolute basics. Check the patient details. Always make sure you have the right patient, the right ward, and the right timestamp. An ABG is a real-time snapshot of a patient's metabolic and respiratory state. Analyzing the wrong strip or even an outdated one from 3 hours ago can completely change your clinical management. Now let's talk about the pH first. The pH is essentially a measure of the acid in your body, and this acid is present in the form of hydrogen ions. The key thing to remember here is that pH is inversely proportional to acid concentration. That means a low pH means there are more hydrogen ions, so there is more acid. Conversely, a high pH means there are fewer hydrogen ions, meaning less acid. In a healthy body, the normal pH range is tightly regulated between 7.35 and 7.45. So when you look at your strip, if a patient has a pH less than 7.35, they are acidotic. If the pH is more than 7.45, they are alkalotic. Now, let's look at PCO2. This stands for partial pressure of carbon dioxide. To really understand how this works, imagine a bottle of soda. Soda has gas dissolved right into the liquid. When the bottle is closed, the pressure inside is high, which forces more gas to stay dissolved in the soda. But as soon as you twist that cap open, the pressure over the liquid drops down to normal atmospheric pressure, and that dissolved gas suddenly starts rushing out of the soda in the form of bubbles. What this tells us is that the amount of gas dissolved in a liquid, which we measure as partial pressure, is directly proportional to the pressure of gas above that liquid. This is a fundamental principle in physics known as Henry's law. A very similar situation happens right inside our lungs. The amount of gas that dissolves into our blood is proportional to the pressure of that gas inside the lungs. Because of this, the lungs have direct control over regulating the amount of carbon dioxide in our body. Think about it. If we start breathing heavily and hyperventilating, we blow off more gas. The partial pressure of carbon dioxide in the lungs drops, and as a result, the partial pressure of carbon dioxide in blood decreases. On the flip side, if we slow down our breathing or hyperventilate, that carbon dioxide builds up, the pressure rises, and the partial pressure of carbon dioxide in the blood goes up. To put this into practice, we need to know the baseline. The normal range for partial pressure of carbon dioxide is 5 to 5.5 kilopascals, which is about 35 to 45 millimeters of mercury. Now here is the ultimate golden rule for reading an ABG. The direction of change in PCO2 with respect to the pH tells you exactly what type of acid-base disorder you are dealing with. If the pH and the PCO2 move in the opposite direction, the primary disorder is respiratory, meaning it's directly related to the patient's ventilation. However, if the pH and PCO2 move in the same direction, the primary disorder is metabolic. It's being caused by an acid or base change in the blood itself, and the respiratory system is just trying to react to it. Now let's talk about the partial pressure of oxygen, or PaO2. Just like carbon dioxide, oxygen dissolves into the blood based on Henry's law, and we can use this value to directly check the oxygenation state of our patient. But here is a critical clinical caveat. This is only reliable if you are looking at an arterial blood gas. A venous blood gas, or VBG, cannot be used to accurately assess oxygenation. VBGs are still incredibly useful, but we'll dive into that a bit later. For arterial blood, evaluating oxygenation isn't as simple as just looking at the PaO2 number. In fact, PaO2 alone is entirely insufficient to tell us how healthy the lungs actually are. Imagine two different patients. Both of them have an identical, completely normal looking PaO2 of 12 kilopascals or 100 millimeters of mercury. On paper, they look the same. But patient A is breathing normal room air, while patient B is on a 100% high flow oxygen mask just to maintain that same number. Their lung health is drastically different. To get the true story, we must account for how much oxygen we are feeding the patient. We do this using a parameter called the PF ratio, which is calculated by dividing the partial pressure of oxygen by the fraction of inspired oxygen the patient is breathing. Let's look at what the normal values for a PF ratio should be, depending on the units your unit utilizes. If using kilopascals, it is more than 50, and if using millimeters of mercury, it is more than 400. If your patient's PF ratio falls significantly below these numbers, it tells you that the lungs are struggling to transfer oxygen into the blood, signaling potential respiratory failure, or ARDS. Now, remember earlier when I said venous blood gases aren't useful for checking how well the lungs are oxygenating? That's absolutely true, But a venous PeO2 has another secret superpower in the hospital. It is incredibly useful for confirming the correct placement of a central venous catheter. You will very often see ICU doctors or anesthetists insert a central line and immediately draw a blood gas straight from the catheter tip. Why? Because the pressure inside a vein can sometimes trick you into thinking you are in an artery or vice versa. By running that sample as a blood gas, a low partial pressure of oxygen, typically around 5 to 6 kilopascals or 40 millimeters of mercury, gives you instant objective confirmation that the line is sitting safely in a vein and has not accidentally cannulated an artery before you start infusing potent medications. Next step on the strip, look at the hemoglobin concentration or HB. Because an ABG gives you a near instant readout, it is often your quickest clue that a patient is acutely losing blood. If you notice a sudden, unexpected drop in your patient's hemoglobin, your immediate clinical priority is to find the source of bleeding and control it. Whether it is a surgical site, a GI bleed, or internal trauma, stop the tap first. Once that bleeding source is controlled, you can recheck the hemoglobin to see where you stand and decide on a transfusion strategy. As a general rule of thumb, you want to trigger a blood transfusion based on these classic thresholds: 70 grams per liter for an otherwise healthy patient and 90 grams per liter for a patient with cardiovascular comorbidities. In patients with underlying heart conditions, their myocardium doesn't tolerate hypoxia well, so we keep that threshold higher to protect their cardiovascular system. Let's look down at electrolytes on the strip. Your ABG or VBG machine provides an incredibly fast turnaround for three heavy hitters: sodium, potassium, and ionized calcium. Before you make any shifts, you need a baseline of what normal generally looks like. Normal range for sodium is 135 to 145, potassium is 3.5 to 5, and ionized calcium is 1.15 to 1.3 millimoles per liter. If you spot an abnormality here, like an acute hyperkalemia or a severe hyponatremia, remember that these values must always be corrected carefully and strictly according to your local hospital guidelines. Correcting electrolytes too quickly or using the wrong fluid protocols can cause severe neurological or cardiac complications, so always pull up your trust's local internet guidelines before you write up the prescription. The next crucial metabolic marker to scan for on your strip is the glucose level. In a hospitalized patient, a normal random blood glucose range typically sits between 6 and 10 millimoles per liter. If you look down and see a low glucose level, hypoglycemia, this can immediately explain why a patient is suddenly confused or presenting with a low GCS. Hypoglycemia is a medical emergency that can lead to permanent neurological damage if missed, so it needs to be corrected ASAP with IV dextrose. On the flip side, if you see a very high glucose level, you need to have a high index of suspicion that your patient could be in diabetic ketoacidosis. If they are in DKA, they need to be started on your hospital's fixed rate insulin DKA protocol right away. And if you suspect this, remember the golden rule. Don't forget to check the blood ketones alongside your blood gas to confirm the diagnosis. Next, we look at lactate. Lactate is one of your absolute best tools in an emergency because it acts as a direct measure of how well perfused your patient's tissues are. Under normal conditions, your cells use oxygen to make energy. But if a patient becomes shocked or severely unwell, oxygen delivery to the tissue drops. The cells are forced to switch over to an emergency backup system called anaerobic metabolism, and the byproduct of that process is lactate. A high lactate level above 2 millimoles per liter is a massive red flag. It suggests that your patient is hypoperfused and likely needs urgent fluid resuscitation, oxygen optimization, and a search for the underlying cause, whether that is sepsis, severe hemorrhage, or cardiogenic shock. Here is a vital tip. Don't just look at the first lactate number, look at the trend. If you give a fluid bolus and the lactate starts coming down, which we call lactate clearance, it tells you your resuscitation is working and tissue perfusion is improving. Remember that the high lactate isn't always just about shock. You can also see elevated lactate from liver failure, since the liver clears it, extreme shivering, seizures, or even medications like metformin and beta agonists. But until proven otherwise, in an acute setting, treat a high lactate as tissue hypoperfusion. Now let's tackle the metabolic engine of our acid-base balance, bicarbonate. While your lungs manage volatile acid by breathing out carbon dioxide, your kidneys are responsible for regulating bicarbonate. Think of bicarbonate as the body's natural chemical sponge. Its primary job is to soak up and neutralize excess acid ions in the blood. In a healthy individual, the normal range for bicarbonate is tightly maintained between 22 and 26 millimoles per liter. When this number shifts outside the normal range, it tells you exactly what kind of metabolic environment is developing in your patient. If bicarbonate is low, it means that chemical sponge is depleted, there isn't enough base to neutralize the acid, which confirms a metabolic acidosis. This happens because the body either is overproducing acid or the kidneys are failing to retain the bicarbonate. If bicarbonate is high, it means that there is an excess of base in the blood, confirming a metabolic alkalosis. This typically happens when the patient is losing acid from the stomach, like severe vomiting, or due to specific diuretic medications making the kidneys excrete too much hydrogen. Right next to your bicarbonate value on the strip, you will almost always see a parameter called base excess, often abbreviated as BE. Think of base excess as the ultimate confirmation tool for your metabolic status. It tells you exactly how many millimoles of strong acid or base you would have to add to 1 liter of blood to get the pH back to a perfectly normal 7.4. In a normal healthy patient, the base excess should sit comfortably between -2 and +2 millimoles per liter. When that number swings outside of this tight range, it simplifies your metabolic assessment. If the base excess is highly negative, this is often called a base deficit. It means that there is a shortage of base in the blood because it's been used up fighting off excess acid. This confirms a metabolic acidosis. If the base excess is highly positive, it means that there is an absolute surplus of base floating around in the blood, confirming a metabolic alkalosis. If you ever find yourself looking at a borderline bicarbonate number and you're just not quite sure if this is a true metabolic issue happening, glance down at the base excess. If it's worse than -2 or higher than +2, it confirms that a true metabolic derangement is underway. Let's put all of this into practice with 4 classic clinical scenarios you will see on the wards. First up, a patient with severe COPD flare-up who is getting tired and hyperventilating. Their ABG shows a pH of 7.28 and a PCO2 of 8.0 kilopascals or 60 millimeters of mercury. Notice how the pH and PCO2 are moving in the opposite directions. That tells you it's a respiratory issue. Because the lungs can't blow off carbon dioxide, the CO2 builds up in the blood and turns into carbonic acid. This is a classic primary respiratory acidosis. Next, imagine a young patient presenting to the emergency department with a severe panic attack, hyperventilating at 30 breaths per minute. The strip reads a pH of 7.52 and a PCO2 of 3.8 kilopascals or 28 millimeters of mercury. Again, the arrows are moving in opposite directions, confirming a respiratory drive. Because they are breathing so fast and heavy, they are blowing off massive amounts of carbon dioxide. Less carbon dioxide in blood means less acid, resulting in a primary respiratory alkalosis. Now let's look at the metabolic side. We have a patient presenting with severe sepsis from an unmanaged infection or perhaps an uncontrolled diabetic in DKA. The values look like this: a pH of 7.21, a PCO2 of 4.2 kilopascals or 31 millimeters of mercury, a bicarb of 14, and a base excess of -10. Look at the pH and PCO2. They are moving in the same direction. Both are low. That immediately points to a metabolic cause. The low bicarbonate and highly negative base excess confirms that the body's chemical sponges are completely used up, trying to buffer the massive influx of metabolic acids. This is a textbook primary metabolic acidosis. Finally, consider an elderly patient who has been suffering from severe protracted vomiting due to a bowel obstruction. Their strip reveals a pH of 7.49, a PCO2 of 6.1 kilopascals or 46 millimeters of mercury, a bicarb of 34, and a base excess of +8. Once more, the pH and PCO2 are moving in the same direction, both are elevated, signaling a metabolic origin. Because the patient has been losing massive amounts of hydrochloric acid from their stomach fluid, it leaves the bloodstream with a relative surplus of base. The high bicarbonate and the positive base excess seal the diagnosis, a primary metabolic alkalosis. And that is how you systematically break down an ABG strip without getting overwhelmed by the numbers. By taking it step by step, checking the patient details, using the arrow rule for pH and PCO2, calculating your PF ratio, and scanning your hemoglobin, electrolytes, glucose, lactate, and metabolic markers, you will never miss a critical clinical clue on your next shift. If you found this step-by-step breakdown helpful, make sure you hit that like button, subscribe to the channel for more high-yield clinical guides, and drop a comment below if you have any questions about the cases we covered today. Thank you so much for watching, stay safe on the wards, and I'll see you in the next video.